Reassessment colonoscopy to diagnose serrated polyposis syndrome in a colorectal cancer screening program. Introduction. Serrated polyposis syndrome, SPS, is a heterogeneous disease arbitrarily defined according to the following World Health Organization (WHO) criteria. 1. At least 5 serrated lesions proximal to the sigmoid colon, with 2 or more of them being at least 10 millimeters in diameter. 2. At least 1 serrated lesion proximal to the sigmoid colon in a patient with a first-degree relative with SPS, or 3. More than 20 serrated lesions spread throughout the colon. SPS prevalence has been reported as between 0.34% and 0.66% of the population in the context of screening programs based on fecal occult blood testing, FOBT. In establishing a diagnosis of SPS, the number of polyps is cumulative, so it is often established after successive procedures. A study showed that up to 45% of SPS patients are not diagnosed at first colonoscopy, even if this is performed by an experienced endoscopist. The presence of numerous or large serrated lesions is a common finding in a fecal immunochemical test, FIT-based colorectal cancer, CRC, screening program. However, surveillance recommendations for patients with serrated lesions remain controversial. The American Gastroenterology Association, AGA, recommends follow-up intervals that range from 3 to 10 years according to location, size, dysplastic component, and histological subtype of any serrated lesions, but annually if one of the WHO criteria of SPS is fulfilled. The European Society of Gastrointestinal Endoscopy, ESGE, proposes a simple approach that takes into account size and dysplastic component. An expert panel has recommended a 3-year surveillance colonoscopy in patients with at least 1 sessile serrated adenoma or polyp, SSA or P, or traditional serrated adenoma, TSA, at least 10 millimeters, 3 or more SSA or Ps, or TSAs of any size, or any number of SSA or Ps with dysplasia. However, the diagnostic yield of surveillance colonoscopy in these patients remains poorly studied. The authors hypothesized that in a FIT-based population screening program, a reassessment colonoscopy in patients with proximal serrated lesions would detect missed SPS patients. Accordingly, the authors' aims were to assess the incremental rate of SPS diagnosis after a reassessment colonoscopy in patients with proximal serrated lesions on their baseline colonoscopy and, secondly, to identify factors predictive of a diagnosis of SPS. Background and study aims. Serrated polyposis syndrome, SPS, is a high-risk condition for colorectal cancer, CRC. Surveillance strategies for patients with serrated lesions remain controversial. The authors aim to evaluate a diagnostic strategy to detect SPS consistently during reassessment colonoscopy in patients with proximal serrated lesions. Methods. This was a retrospective study of all individuals from a fecal immunochemical test, FIT-based CRC screening program, 2010 to 2013, with 1 or more serrated lesions at least 5 millimeters proximal to the sigmoid colon on baseline colonoscopy. Rivero-Sanchez et al. Analyzed all individuals empirically scheduled for a reassessment colonoscopy aimed at diagnosing SPS within 1 year. Reassessment colonoscopy was performed with standard white light or chromoendoscopy plus or minus high-definition endoscopy, depending on availability. SPS diagnosis was based on the cumulative number of polyps in both the baseline and reassessment colonoscopies. Factors associated with SPS diagnosis were analyzed. Results. From 3,444 screening colonoscopies, 196 patients met the study entry criteria, of whom 11 patients met the criteria for SPS on baseline colonoscopy. Reassessment colonoscopies were performed in 71 patients and 11.9 plus or minus 1.7 months and detected 20 additional patients with SPS, a tripling of the rate of SPS up to 0.90%. Independent factors associated with SPS diagnosis were having 5 or more proximal serrated lesions or 2 or more sessile serrated polyps of at least 10 millimeters on baseline colonoscopy and the use of chromoendoscopy plus or minus high-definition endoscopy during reassessment colonoscopy. Conclusion. A 1-year reassessment colonoscopy using chromoendoscopy and high-definition endoscopes substantially improves SPS detection in individuals from a FIT-based screening program with proximal serrated lesions. 5 or more proximal serrated lesions or 2 or more sessile serrated polyps of at least 10 millimeters could be thresholds for requiring a reassessment colonoscopy. Prospective studies are required to validate these results and adjust surveillance recommendations in patients with serrated lesions.